Hey guys, welcome to this webinar today on Intro to Emergency Medicine. Super excited to talk to all of you guys, and I'm thankful for everyone that was part of bringing this together. This was a phenomenal group that got everything situated. And I'm just so excited to be able to share some information with you guys and learn from you guys as well. But I thought today will be a phenomenal opportunity to just start from the background and talk about the intro to emergency medicine as a specialty that what we've seen grow and the going to the components of emergency medicine pharmacy and talk about a few key aspects related to that. But before we get going, one of the things that we talk about quite a bit is making sure that we release any disclosures, and I have no real or apparent conflicts of interest. I won't be discussing anything off-label or investigational uses of medications in this presentation. So the first question that really starts off is how did emergency medicine evolve? Like what was the initial thing? Because here in the US, we didn't necessarily have a very robust system prior to the 1960s, and this was going to be post-war. And a lot of what we've learned was happening in the early 1960s that emergency medicine emerged during this time, but we still had close to 20 years before the American Board of Medical Specialties actually recognized emergency medicine as a medical specialty. And it's a phenomenal film out there that is called 24/7, 365, The Evolution of Emergency Medicine, that is really good at describing everything that goes on. And I think it's something that if you guys have time, it'd be a phenomenal thing for you guys to watch. But after World War III, what we noticed is people start moving to different cities, and they started moving from the rural areas to more of the metropolitan areas and bringing in a lot more volume of patients. And many people came and when they did not have an emergency medicine doctor, they didn't have a family medicine doctor. So a lot of what happened was that these patients would go a prolonged period of time without care. And what we noticed that is led to an increased use of hospitals for the exacerbation of chronic conditions. And we also starting to know at this time as well is that we're starting to do better with sanitary conditions. And we have the first of this expanding age and aging population to start to age at this time frame in the U.S. And we starting to see a lot more people present to our emergency departments. Some family doctors were getting replaced by specialists, and what we saw was that specialists didn't want to see patients outside of their office hours, and the increase in specialists led to more people going to the hospitals, especially for emergency cases. Because again, you had more specialists that can take care of more specialized activity, but again, it didn't necessarily mean that people had better access to these specialists. So that was something that was unique that led to the increased volumes of patients presenting to the ER. So was that in the emergency departments, in the emergency room, we did see an increase in volumes. There was a lack, however, of infrastructure because these hospitals were not prepared for this volume. And what we saw initially in the early 60s were our ERs were underdeveloped, understaffed, and there was a lack of management. And what this led to was the fact that we had the least experienced physicians taking care of the most dangerous cases. So in our care, we had the most junior providers taking care of patients that had these very severe illnesses and traumas and things that really needed a little bit more expert care. But however, it just wasn't the way of how emergency medicine worked at that time, and that led to again we having cases where things went wrong, and it led to a lot of blame being made on these hospital systems. Just a few pictures of what the emergency medicine department used to look like, and is having a gurney and a few lamps that was just available that we would find some space and treat patients, and this is just what we had, and that was just unique of the not unique of the time. We'll have patients put in different locations that we would see and try to take care of them the best that we could. Again, this is just showing a difference in how things are today compared to how they was in the 60s here. And it's something that was unique because, again, we thought that we were doing a lot of different things. And again, having our providers that were the most junior taking care of these more severe patients, we thought that was just the way that things went. And as we would notice through this period of time, things changed pretty dramatically. So as we go through this evolution of emergency medicine, there's a few things that happen, and I want to point out a couple of things here in 1961. The Pontiac Plan, which we'll talk about a little bit more, we had part-time community physicians begin to work in emergency department or emergency room, as I use those terms, kind of interdisciplinary. I use those terms really intermingled throughout this presentation. That plan, and then the Alexandria Plan, where we had full-time attending patient physicians taking care of patients in the ER, something that was unique as well. Another some key things here, we had the American Medical Association establish committees on emergency medicine. So again, not necessarily recognizing, but we're starting to see at least an interest in that from our major organizations. And we had some of our providers actually start what is one of the more successful emergency medicine physician organizations, ASAP, or the American College of Emergency Physicians in 1968. So I mentioned the Pontiac Plan, and this was what's developed in Pontiac, Michigan. And again, this is where we had attending physicians work part-time in ER and rotating shifts. The big thing about this was that it had varying specialties. So there could be a dermatologist, there could be someone who was a neurologist, there could be someone who could be an internalist, but all these different specialties that staffed these patients and saw these patients, which was different than our most junior physician taking care of these patients, but again, it still was a little different, and it definitely had some levels of criticism. And while we had people work part-time in the ER, they didn't, again, had different levels of training. And for those who work in the ER or who's been involved, you'd notice that it takes a lot of different skills and training to be a proficient in such a large variety of different disease states that you would see. And then around the same time, we had the Alexandria Plan that was done by the famous Dr. James Mill, and this where he formed a team of physicians to staff the emergency department full time in Alexandria Hospital in Virginia. And this was great. It was the first full time emergency medicine physicians that were approved by the hospital board and the city. And this was thought to be a more viable plan. And this led to a great deal of publicity and replication throughout the US. But this was something that was unique for emergency medicine because, again, just a few years earlier, we were basically sending anyone who we didn't want to deal with during our physician training and putting them in these locations to take care of these very sick patients. So as we continue moving forward in 1970, some medical students were already choosing emergency medicine as their specialty. So just 10 years after some of these big changes, we're already having people transition to doing this full time. And in 1970 as well, Dr. Bruce Janiak became the first EM emergency medicine resident at the University of Cincinnati. And a cool note was that I actually was able to practice with him prior to him retiring when I worked at Augusta University Medical Center, and I got to work with him and listen to some of the stories, and he was just as enthusiastic as he probably was in 1970. So that was a very interesting thing. And then moving forward, looking at this timeline here, we see that R.R. Haynes had actually established the first community hospital emergency medicine residency program just a few years later. So we're starting to gain some steam and not only the recognition of emergency medicine, but also in building training facilities to build a foundation and having students interested in emergency medicine. And then move forward to 1974, the Emergency Medicine Residency Association, EMRA, was formed to unite the initial residents of emergency medicine. This is another big thing in organizations that are still around today, and they've done a phenomenal job with helping our physician colleagues. Moving forward now to the 1980s, what we start to see is that the AMB administered the first emergency medicine board exam, which is a huge step forward. And then the American Council for Graduate Medical Education approved special requirements for emergency medicine residency training programs. And then in 1989, we had a few things happen. We had the emergency medicine became a primary board by the ABMS, and then the initial track where basically you can just practice your way into emergency medicine was likely closed in 1989. So what that meant was that all of our physician colleagues who practice and did not have formal training didn't necessarily meet criteria for certification anymore. So that was a pretty big controversial thing that happened back then, but it led to formalizing the process of training to be involved in emergency medicine. And the AUEMS and the Society for Teachers in Emergency Medicine, STEM, they actually merged to become the Society of Active Emergency Medicine, or SAEM, which is a very large organization that is still ran to this day, and they've had a significant amount of success. And this was founded again in 1989. So fast forward, there's a few things that happened in the 90s, but I want to get you guys kind of caught up to the pharmacy part of this. But fast forward to 2010, we have over 157 allopathic EM programs, and we have 37 osteopathic EM programs, and that's continued to grow. I believe that number probably puts us closer to over 200 programs that are out there. So it's very unique what we've been able to do and build. And I'm fortunate that I was able to practice with the first emergency medicine physician resident and see how far emergency medicine has come and how they've laid the foundation to what EM is today. So now we've had a good talk about emergency medicine in general, just the specialty in itself, and paying a special amount of attention to the medical physicians. Let us move forward now and have a talk about emergency medicine pharmacy. And this is something I've been very fortunate to be involved with my career that I'm super passionate about and really thankful for the work that's been done in this space over the last 40 to 50 years. So, what is emergency medicine pharmacy? And speaking from the American College of Clinical Pharmacy and the American Society of Health System Pharmacy, they define an emergency medicine pharmacist, or EMP, as one who specializes in the delivery of direct care, patient care at the bedside, and cares for patients across a diverse populations and acuity levels. These specialists are critical members of the interprofessional emergency medicine team, can anticipate pharmacotherapy needs in a fast-paced environment of the emergency department, and have expertise in the management of time-dependent emergencies, pre-hospital medicine, emergency preparedness, public health, and toxicology. Emergency medicine pharmacy practice focuses on a rapid assessment of available patient data to optimize pharmacotherapy, improve patient safety, increase efficiency and cost effectiveness of care, facilitate medication stewardship, educate patients and healthcare clinicians, and contribute to research and scholarly activity. So that's a mouthful, but it really captures a significant amount of what we and what I've been able to strive to be as an emergency medicine pharmacist. So as we did with our physician colleagues, we can take a look back here in the US and really talk about some of the pioneers of emergency medicine pharmacy. And Dr. Robert Ellenboss was a pioneer of emergency medicine pharmacy, and he practiced at Truman Medical Center in Kansas City, Missouri. He actually became the first director of the American College of Clinical Pharmacy, which he also founded. And in the U.S., clinical pharmacy services in the ED started in around 1970. So again, our physician colleagues have been working their way through things for about 10-ish years until this happened, until we start having dedicated pharmacists come down to the ED and help out with our physician colleagues. And as we move forward, we can see that this article published by Dr. Robert Hellenbaum in 1972 in the New England Journal of Medicine, and it was titled "The Pharmacist on a Resuscitation Team." This was a letter to the editor, and he mentioned that as a member of the CPR team or Code Blue team at the University of California, San Francisco hospitals, I was interested in an article by Lemire Johnson and an accompanying editorial in the May 4th edition of the journal. And he wanted to talk about the importance of a well-organized, efficient CPR team that can't be overemphasized. It is the regard that I'm writing, and it's included on our Code Blue team as a member of the clinical pharmacy staff. It is the pharmacist's responsibility to prepare and record medications given during the resuscitation attempt. There are several advantages to having a pharmacist serve this function because the same person is always performing this task. He's able to do so rapidly, efficiently, and most of all, accurately. By recording medications given, he is able to ensure that the proper drugs are given often enough or not too often in the proper dosage. Also, as experience is gained, the pharmacist is often able to predict which medications will be needed and to have them prepared before they are called for. I urge all hospitals and medical centers to include the pharmacist as a member of the CPR team. The pharmacist, in his expanding role as a drug therapy consultant, can be a very useful member of this team. And this is very unique because this is something that we can plant our roots in when looking at emergency medicine pharmacy. Articles like this and having data out there that goes back to 1972 lets us know that this didn't start overnight. It's something that was thought about and something that's been implemented in many centers since the 1970s. When talking about the first pharmacy training programs for those interested in emergency medicine and toxicology, which was the first two like intermingled specialties, again, emergency medicine, toxicology, since they're so similar. I spoke to Frank Polishek, who's one of the early pioneers within pharmacy as well, and he mentioned that Joe Barrett went and started an EM program at Rutgers, and right after finishing UIC in 1981, which Frank was headed of, and probably the longest continued of them all. Not sure the starting years, but Mary Ann Holland, NYC, again, Shane Shobin had an ED Talk program back then as well. When they're talking about the initial program, he said my very first PGY2 EM Talk resident was Sue Gorman. She left after a year to take a dream faculty position. And first to complete a 2-year program was Kevin Wren and Don Tillman in 1992. It was a 2-year contract for PGY1, PGY2, which ultimately was an early commitment. So again, I think it's just interesting to see that this is something that mirrors very closely to our physician colleagues as well, the early years of EM. And when speaking of the first accredited program, because again, that's something that's key as well, that we usually get to see a little bit more documentation of. The first PGY2 or postgraduate year 2 program in emergency medicine pharmacy was established at Detroit Receiving Hospital. And the second accredited program was launched shortly after by the University of Rochester Medical Center in New York. So when speaking of these early years, the service provided by the pharmacy department and in the emergency department itself is uncommon, and only a few large urban emergency departments had it. EM pharmacists became a walk-in pharmacology book as they were responding to various questions regarding drug information. Later on, EM pharmacists took several shifts, even night shifts, to be present when the number of patients increased. One of the big things that really led to an increase in the presence of EM pharmacy was the medication errors that happened in the ED. What we found was that medication error is any error in the medication process, regardless of a patient experiences an adverse consequence. And what we found is that thousands of Americans die each year as a result of medication errors, and approximately half of these errors occurred during a hospitalization. And from a cost standpoint, what's been shown was that an estimate of $29 billion is spent each year in the US as a result of medication errors. So anything we can do that can decrease that, and pharmacists are key people involved in the process, we definitely want to figure out how to eliminate any of these errors. Well, looking at some statistics, we found that a recent study showed that 59% of patients had one or more medication errors, and the ED had the highest rate of preventable errors, with 120 million ED patients yearly in the US. 5% of these experienced potential events. 70% of these errors were preventable. 77% of all ED medication errors happened between the ordering phase and administration phase. 23% of these errors were discovered before the patient received medications, and 39% in other areas of the hospital. So again, one of the biggest areas and locations that this happened, we can spend effort on, is in the emergency department. And this data was presented by the National Center for Health Statistics, and another study that was part of this data set was the Harvard Medical Practice Study. So as we look at all of this, we want to figure out if someone's interested in medication errors, what's something we can do to identify whether or not a pharmacist can be part of this, or if there is something we can do. And there's a program that was created in order to provide a positive contribution to pharmacy services in the emergency department in the early 2000s. And I was very fortunate to speak with the creators of this and have contacts with them and to get a context of what they did and the impact that they did. And I don't think they really understood how big this was going to be for emergency medicine pharmacy. But let's jump into clinical pharmacy program by Dr. Terry Fairbanks. And in early November 2004, Dr. Fairbanks and colleagues proposed a pilot program that tested and implemented an ED-based clinical pharmacist program at an AD of a level 1 trauma center and an academic medical center that was pretty large, 739 licensed inpatient bed. And this site was the University of Rochester in New York. This program again aimed to determine the positive changes when a clinical pharmacy was assigned to the ED, and these changes pertain to the reduction of medication errors in the emergency department. So in this program, the ED clinical specialist, or the CPS position, was assigned to a clinical pharmacy with a doctor of pharmacy degree who was in the emergency department on Monday through Friday from 10 a.m. to 6 p.m. This clinical pharmacy specialist was given a designated computer with access to online references and carried a portable telephone to be easily accessible to the nursing and physician staff in the emergency department. And that role that was defined in this clinical pharmacy program by Dr. Fairbanks and his team, well, they want to see what happened when they assigned the clinical pharmacy specialist these roles. And what those roles were clinical pharmacy consultant, care of patients that were boarded, or patients that was still physically in the emergency department, but assigned to an inpatient team in the other aspects of the hospital. They also looked at what happened when that pharmacist provided patient education, when it involved in emergency preparedness, order screening, staff education, dispensing of certain medications, stocking of those medications in the ER as well. A huge component was resuscitation response and preparation of medications in the emergency department for all of these cases. As expected, the program was massively successful and led to some positive changes to the traditional ED practice. And this is where a lot of the growth of ED pharmacy originated from. And the fact that Dr. Terry Fairbanks was a physician actually looking at this from a pharmacy perspective really helped out tremendously. And Dr. Fairbanks and his team concluded that the provision of clinical services in ED by pharmacists appeared to have improved medical care, imparted knowledge to the ED personnel, and reduced ED institutional expenditures. So we were able to be safe, we were able to educate, and show that we can reduce costs when pertaining to things that happen in the hospital. So some of these positive changes that were brought on by this program were by interventions in prescribing practice. The clinical pharmacy specialist was able to reduce the amount of high-cost medications by replacing them with equally effective, lower-cost medication. And there's also a case in where a clinical pharmacy specialist was able to prevent the administration of a contraindicated medication. So that is something that comes up quite frequently, especially in my own practice, that we prevent someone from giving a medication they probably don't actually want to give, and we stop them from doing it before they actually reach the patient. And over this period of time, we've seen extensive growth after the presentation of all these findings by Dr. Fairbanks. We start to see an increased growth in the pharmacy residency programs and just people wanting to become EM pharmacists, and the recognition from our physician colleagues and by white papers and things of that nature led to us getting to the point to where board certification was really a big thing for pharmacy, and we didn't necessarily in emergency medicine have a board certification that provided us with our own, but in February 21st of 2020, an article was published on the website of the Board of Pharmacy Specialists stating that emergency medicine pharmacy is formally recognized at the 14th pharmacy specialty. So it followed the same path as our physician colleagues, where we started some of the work and providing some of the evidence. But again, it took a little while for us to get to the point where we was actually considered and recognized by the Board of Pharmacy as a pharmacy specialty. And what they wrote was that the BPS is pleased to formally acknowledge emergency medicine pharmacy as a new pharmacy specialty. And the addition of this specialty underscores the growth of pharmacy specialization, as well as a recognition of expanded patient care responsibilities of pharmacists in this practice area. Also worth noting was the fact that over 200 physicians and 70 nurses submitted public comments in support of a petition that recognized pharmacists, EM, as a pharmacy specialty. And that really just goes to show the work that's been done by our colleagues that also work in the ER and the support that we have for them. So this was a monumental movement for emergency medicine pharmacy. And when speaking of the residency growth, it was definitely intriguing to see we've seen an expansion in the available specialty programs, and the number of accredited training programs risen from 3 in 2007 to 70 in 2020. That provided to be a 2,000% increase in specialty training in just over a decade. And I can tell you that just over the last few years that number has went up tremendously. So it's exponential growth in the training and the recognition of emergency medicine as a pharmacy specialty. So let's transition into one of the more interesting parts of the presentation, the roles and the duty of an emergency medicine pharmacist. And this is something that varies quite a bit from institution to institution, and I'm pretty sure from region to region. So this is going to be interesting and something I love to talk about because I'm fortunate where I'm able to practice at the top of my license and do some pretty interesting things on a day-to-day basis. So when speaking of the roles and duties of emergency medicine pharmacists, Morgan and Cox really stated that the guidelines for EM pharmacists define the role of a clinical pharmacist in ED and suggested goals for pharmacy services to meet institutional and establish best practices. And this is one of the more busy graphs, but I think what it does is really help us understand what's going on. And I'll try to walk us through all of this because it can get pretty busy if you look at everything. But I like to kind of start off and think about again all the things that we do depending on the time. So we're starting here. I look at the patient arrival to the emergency department. Before they get there, what are the things that we're doing? And when it comes to that, we're thinking about things like institutional and professional contributions. That's going to be formulary management. What agent can we use in the hospital, and how can we go about adding monographs and help out with formulary approvals or restrictions, and how can we ensure of that? Another component can be care pathway development that we have here is number 2. So again, if a patient comes in with pneumonia, do we have certain processes and protocols in place that the pharmacy has had their hands on to guide the correct therapy when we're not there, and even to ensure when we don't get around to certain things, we can really ensure continuity of care by making and establishing these guidelines. Other component can be education for interdisciplinary care teams. This is something that is really key to making sure that our team is able to receive the best education about the latest pharmaceutical news, whether it's shortages, things of that nature, or what's the best therapies based on the latest studies. So again, something that we can really drive in and help our nurses, physicians, and other healthcare workers that are with us in the ER. Next thing can be medication safety and quality improvement initiatives, where we can find out different processes and find out the things that are potentially hurting our patients, find out the things that we can improve on consistently, and really put in processes to ensure that this happens consistently and meet with the appropriate stakeholders to ensure that these things are getting done. Emergency preparedness participation is also really key, and we're fortunate to be in a position to where we understand the gratitude of all of these things and being able to help out with the stock of emergency medications during these mass casualties or these very emergency preparedness events, and participating in the trainings and being involved in all aspects of this. And we've been very fortunate over the years to have some pharmacists come out and really take a lead with this and being able to educate other pharmacists on how to participate in emergency preparedness. Research and scholarly activities are also big, being able to contribute to the literature when it comes to pharmaceuticals and we come to pharmacotherapy, especially in the ER. I think it's only right that we're involved in educating and we're involved in the decisions at the bedside. It's best for us to also participate in research. So that's all before. So when the patient arrives here, there's a ton of things we can do at the bedside. We're going to walk through each part and talk about what other people are doing. I think is really unique where we have our ED physician evaluation. This is where we provide drug information and toxicology services. If they're evaluating a patient, they notice a few things. We can say whether or not a drug has caused that, or we can say what's the antidote to a particular toxicology event and be heavily involved with that. And once we have the evaluation complete, we can be involved in the drug therapy consultation. What's the best drug for this patient now? Now that we understand what's going on, and then once that medication therapy has been ordered by the physician or our mid-level practitioner, we can provide drug therapy recommendations during the order verification process if he wasn't involved early on. So if I didn't talk to the provider and he ordered something I think is an optimal way to utilize it, I can get really involved in that as well. Once we get through that process, we can be involved in the medication procurement and preparation for our critical patients. If I have a patient that needs vasopressors immediately, I can be heavily involved with that. We can guide drug administration by our ED nurses, and then we can be involved in the patient reassessment, figuring out what other components need to be monitored based off that drug. And then that's not including the resuscitation-like events, the medical and trauma resuscitations like cardiac arrest and strokes, participate in time-sensitive disease states like ischemic strokes, hemorrhagic strokes, myocardial infarctions, and sepsis, and where there could be high-risk medications used and procedures like rapid sequence intubation or procedural sedation. So we'll be heavily involved in all of these processes where we're making recommendations, we're getting medications, preparing medications, and making sure they're utilized in the best way possible. And then once a patient has a disposition, whether they're going to get admitted for inpatient care, we can help out from a medication history standpoint to ensure that the right medication is continued from home, or they're going to be going home with a medication that they can be on the right medication as well. Then we can provide some assistance with patients that are boarded as well if they hang out in the ED. And then for those patients that get discharged, we can have recommendations for discharge prescriptions. We can do patient education and counseling. And one of my favorites is post-discharge microbiology culture review. If we get a urine culture or blood culture and something comes back positive, we can be heavily involved in the selection of the antibiotics for those patients. So tons of stuff that we can be involved in emergency department. I think the biggest thing that we can see is that it can be broken up into many areas, whereas clinical, academic, research, administrative, distributive, and emergency preparedness. So when it comes to clinical consultations, we can attend rounds and present patient information. We can have dose recommendations, therapeutic substitutions, or disease state specific pharmacotherapy recommendations. And we can talk to people about the pharmacokinetic profile of these drugs that have been utilized. Other components we can be involved in for our clinical duties is order screening, so focusing on allergies, drug interaction, and appropriate dosing. And then mentioning some of these preparation of these select medications that are high risk, or making sure it's the most appropriate medication for the patient. Resuscitation, again, as we mentioned before, is going to be pretty key, being there during resuscitation and trauma at the bedside, overseeing the whole entire medication use process. Then there's a host of other things we can be involved in. And resuscitation may include a variety of responsibilities, but not limited to, again, assisting the clinician with the differential diagnosis, particularly when it's a potential drug related problem, ensuring the appropriate medication selection and dose, answering different medication questions. We can also be making recommendations for alternative routes of administration when appropriate, and prepare these medications for immediate administration. We can also ensure appropriate administration or the administration of medication pursuant to our local scope of practice. Again, there are some places here in the U.S. that where pharmacists are allowed to give these medications, are very comfortable giving these medications. We can obtain medications that are not readily available in the ED, like from a central pharmacy location, and be heavily involved in that process. And we can also complete resuscitation documentation, as Dr. Robert Ellenbaum did in the 1970s. One of the things that we have to look at is that a EM pharmacist should always be available and invisible. And this is something that is a foundation. So again, just having an ER pharmacist is one thing, but again, that emergency medicine pharmacist being available and present is really a foundational component. And we should be present at the patient bedside when key decisions are being made about medications. And we need to have somebody who's dedicated to the emergency department. Mentioned earlier, you want to be physically located there, and then should be provided with a computer and online resources. And again, we want to make, again, I keep mentioning this over and over, your EM pharmacy want to be easily accessible and visible to all staff with frequent walkthroughs. And of course, being available by pager or portable phone. We had mentioned this earlier, but a key thing about EM pharmacists and pediatric patients, we really want to be there to ensure that weight-based dosing is being done, that the medications are appropriate and accurate, and really with pediatric patients, you have to be very patient-specific with your pharmacotherapy recommendations and helping people out whether you're translating information from the adult population to a pediatric, you want to be very patient-specific with your pharmacotherapy. And of course, a medical emergency attendant is going to be key in this patient population as well. As an educator, so many opportunities. We can have medication specific education, or we can have disease state specific things like asthma and making sure inhalers are being used correctly, warfarin, whether we're ensuring our patient doesn't have any drug interactions or food drug interactions, low molecular weight heparin, again, the administration of some of these agents. Diabetes management. Again, there's a ton of data looking at pharmacists being very involved in the management of patients with diabetes and how we can help them with lifestyle modifications and adjustments of their medication, whether it's doses or ensure that they're on the right medication for what they have going on. Discharge counseling is going to be something that's pretty key in the emergency department to ensure that patients are taking the medications in the most appropriate manner. Also, smoking cessation. Depending on the resources that you have, it can be a great location to spot patients who may have had an event that occurred that makes them say, hey, I may want to stop smoking now. This is something that you can get them involved with. Over-the-counter products, again, depending on if you have access to these or if you have a good knowledge of these medications. You can guide patients to receive these medications once they go to a retail pharmacy. And definitely making sure you ensure as an EM pharmacist for patient compliance. When looking at the emergency medicine pharmacist as an educator, our nursing colleagues really enjoy us providing education for them. We can conduct continued education sessions. We can let them know about new medications and whether there's any drug warnings that come up, whether that be drug-drug interactions, things of that nature. We can also create and be involved in mock cardiac arrest or mock codes or any medical emergencies and really pay special attention to helping our nursing colleagues understand the utilization of medications during this process. Also, the same thing when it comes to high-risk medications, like your aspirins, like your anticoagulants, your insulins, your potassiums. Again, really making sure those medications are used correctly and making sure you're really focused on safe medication administration and helping our nursing staff out when that is something that comes up. When looking at other healthcare provider education, we can again ensure that we're providing up-to-date evidence-based research on pharmacological therapies. We can develop these pharmacology elective for residents, something I've been fortunate to be able to do. We can become an established authority through education. I think this is something that is very unique to pharmacists. We can really be heavily involved in education that really allows the physicians to come to us and really seek us out when it comes to certain things they don't know. And when speaking about being involved in research, again, this can be great for us. You can assist with research for improving patient safety in emergency medicine. We can initiate or coordinate clinical or practice-based research in our EM populations. And this can be something where we can have interdisciplinary emergency medicine clinical research. And we can have identification of patients for enrollment of investigational drug therapies in the emergency department. Another component is participation in the interdisciplinary research committees that review ED-related research protocols that ensure things are going correctly. We can be involved in EM-related research grant preparation or EM medical resident research projects or quality improvement projects. And we can participate in articles, book chapters, case reports, or other collaborations with our EM physicians. So there's a host of things that we can really be involved in when it comes to emergency medicine pharmacists and research. As I mentioned before, again, guideline development or development of clinical pathways are going to be really big here, and some areas that we've seen utilization over the years is community-acquired pneumonia, procedural sedation, analgesic and antipyretics in pediatric, febrile neutropenia, acute myocardial infarctions, So when looking at pharmacotherapy optimization by pharmacists, the role of the team in a trauma resuscitation is that the pharmacotherapy of managing acutely injured patients presenting to the ED, and their pharmacists are working knowledge of trauma, and it's essential given the time sensitive and the potential chaotic nature of resuscitation in these patients. And we can just kind of help take over that process and really be a voice for our emergency medicine teams. Well, looking at the management of stroke, it's pretty interesting to note that retrospective studies actually attempt to show that pharmacists may actually have a beneficial impact on the door to TPA time and in patient care in the emergency department. Intravenous alteplase or recombinant tissue plasma management activator has been shown to provide neurologic improvement and better outcomes if administered early to ischemic stroke patients. So if we can help out and improving that door to TPA time, we're actually maybe actually providing better impact for these patients. I mentioned toxicology. Pharmacists can provide guidance in regards to managing both various toxicological emergencies, particularly when looking at antidote dosing and timeliness of, as well as stocking of these antidotes in the hospital. We'll look at things like procedural sedation, analgesia in the emergency department. This is something that's the bread and butter. ED pharmacists can be a great assistance in selection and individualizing drug therapy and preventing medication errors in these patient populations. And deep levels of sedation in the ER are associated with increased mortality. So we want to make sure that post-intubation sedative should be dose titrated to achieve a lighter level of sedation in the emergency department. And antimicrobial stewardship is going to be another large area where emergency medicine pharmacists are heavily involved, and ED pharmacists can successfully adopt and manage such a program for patients discharged from the ER, not only improving antimicrobial therapy, but patient outcomes in the ER. So again, we can look at patients going home on therapies, but we can also make sure we're utilizing antimicrobials the most correctly in the ER, patients that may get admitted as well. So we mentioned a lot of the role and what we can do. We kind of space those things out, really talk about it from a graphic form, and we laid them out piece by piece. And in the last part, we're going to talk about here the literature on emergency medicine pharmacists. So what does the data even say about us? And I think it's very unique, and I'm always very proud to look at the data that's been presented about ED pharmacists. So one of the big things is using pharmacists as a means of cost containment in the ED. And when looking at this done by Dr. Pat in 2003, it said economic constraints have generally precluded the incorporation of ED-based clinical pharmacists, but because of the enormous economic burden associated with adverse drug events, it may be more cost effective to use high-level experts of an in-house clinical pharmacist. So one of the cool studies that looked at this was done by Levy and colleagues and published in 1993. And what they did was look at a study period from 1989 to 1981 at a ED that was affiliated with a large academic medical center. And they utilized documentations of clinical interventions and utilized different information to utilize a documentation card for more input from their team. So when looking at these number of interventions, what they found was that in 1989, they had about 9,700 interventions, and they found a cost savings that was close to 31,000. 1990, of course, that the number of interventions increased to close to 16,000, and they saw a cost savings of 54,000. In 1991, again, they saw a similar amount of close to 1,600 interventions that was actually associated with $93,000. So that was something that was major for this intervention, and the two major interventions was medication selection and dose changing. Some other studies that was done in around the same time frame in the early 2000s, basically one of Ling and colleagues, they basically looked at something similar where they had a 4-month period. They had about 647 interventions by ED pharmacists, and they found a cost savings of 192,000. That was annualized to close to $578,000. Letterman Lauder and colleagues in 2007 looked at close to 1,400 interventions by ED pharmacists, and they found $1 million in cost avoidance, and that was annualized to $3 million. Audits and colleagues did the same thing, and for a 6-month period, and found close to 9,500 interventions by EM pharmacy that showed $845,000 cost avoidance, and that was annualized to $1.7 million. A few of the things that we can look at here is looking at the interventions and the things that we actually provide as a clinical outcome. And we found that ED pharmacists are associated with reduction in median door to TPA time by 20 minutes. From a sepsis standpoint, they reduced the median time to appropriate antibiotic selection by 44 minutes and increased the percentage of patients receiving guideline adherent empiric antibiotics by 23.6%. Looking at myocardial infarction, something similar, we increased the door to cath lab time by 13 minutes and the door to balloon time by 11.5 minutes. And looking at it from an antimicrobial stewardship standpoint, a host of things we can do. We can reduce the median time to review positive cultures and time to patient or physician notification by 1 day. We can increase the percentage of interventions for inappropriate antimicrobial stewardship therapy based on culture data by 30%. There's also a reduction in percentage of unplanned readmissions to the ED after culture review by 12% and reduction in percentage of inappropriate revision of antibiotics after culture review by 31.9%. And this here we've also shown a reduction in percentage of return ED visits among uninsured patients after culture review by 12.9%. We're looking at other disease states. We're looking at rapid sequence intubation. We saw a decreased time to post-intubation sedation by 19 minutes and a decrease in analgesic medication by 23%. Looking at transitions of care, this is a really key point here. There was intervention on a total of 10% of discharge prescriptions for error prevention and ophthalmologist therapy. We found that a reduction in ED visits by 50% of patients who were given free-to-go antibiotic therapies at a treatment for urinary tract infection, pyelonephritis, cellulitis, or dental infection at an ED discharge. We also found that ED pharmacists are associated with improved medication and disease state education, identification of adherent issues, medication therapy optimization in patients with chief complaints of asthma, COPD, or chronic heart failure. A few of the things that we looked at: dose optimization, increased the percentage of patients receiving optimal phenytoin loading dose by 32%. And looking at vaccination, it was a fourfold increase in the rate of influenza vaccinations. So it's a host of things that we mentioned in this presentation, but EM pharmacy as a profession, there's a host of benefits. Something to look at is the benefits of a practice or a service include a few things: improve health outcomes for patients as a result of early medication reconciliation, medication order verification, and clinical review. What we do is we increase the awareness of medication-related issues amongst ED staff. ED pharmacists also provide as a liaison between emergency, pharmacy, and other inpatient departments on medication-related issues. Timely supply and review of specialized medications. We also improve the communication between ED and external services, such as warfarin monitoring, resident care facilities, and community pharmacy as well. So we're looking at training here. What we usually see is successful completion of a PGY1, postgraduate training 1 year, whether that's pharmacy practice residency or equivalent training, and then there's a host of us, and a lot of us are moving towards this completion of a second year postgraduate education in critical care or emergency medicine, and general pharmacotherapy is acceptable. Some of the skills that are highly desired is BCPS, board certification of pharmacotherapy certification, and I'm pretty sure now that we have our own emergency medicine board certification, that's going to be pretty big. We want to make sure we have ACLS and PALS course completion. We also want to make sure we're trauma course completion as well to be a well-rounded pharmacist. So as a summary, again, emergency medicine is a new and expanding field within medicine. And emergency medicine pharmacy in itself have a history going back to the 1970s. And actually, there are a variety of clinical administrative tasks that are within emergency medicine pharmacist job description. And I think that the more we look into this, the more we would see that EM pharmacists can provide a very great job satisfaction, and we can be very helpful for our patients and the hospital system.